Assalamu alaikum and welcome to the new lecture on heart failure. I am Shoaib Muhammad, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. The material for this lecture has been taken from Clinical Pharmacy and Therapeutics by Roger Walker, Kaizen Basic and Clinical Pharmacology, and Lippincott Pharmacology by Lippincott and William Walken. So this is the outline of today's lecture. Firstly, we will be having an introduction of heart failure. Then we will be discussing the compensatory physiological responses for the heart failure, and then what is the goal of the treatment, what will be the order of the therapy, and how we will carry on the treatment. So firstly, definition of heart failure. So what is heart failure? It is a complex progressive disorder in which heart is unable to pump sufficient blood to meet the needs of the body. Firstly, it's a complex process. As we go into the details, you will see that a number of mechanisms are involved in the heart failure. And secondly, it is a progressive disorder. This problem does not appear suddenly. There is decrease into the functioning of the heart by time, and then we call it as the heart failure. And what happens in that, the heart is not able to pump sufficient amount of the blood to different parts of the body. Why? Because the heart is not contracting properly or supplying the drug properly to the different parts of the body. So it is unable to pump sufficient blood to meet the requirements of the body. What will be the symptoms of heart failure? These include the dyspnea, fatigue, and fluid retention. Why these three common symptoms, major symptoms? Number one is the dyspnea. This is the decrease into the breathing rate. Okay, the patient will be unable to breathe properly. Okay, there will be increased respiration episodes because the heart is not providing sufficient amount of the blood to the body, and the body's need of the uh, oxygen will be increased. That's why the respiratory rate will be increased, and also in some situations there is fluid retention into the lungs. We call it the pulmonary edema, and because of that the patient may also be suffering from the dyspnea. There will be fatigue to the patient. Of course, if sufficient amount of the blood, the oxygen and the nutrients are not supplied to the different parts of the body, the patient will be suffering from the fatigueness. And finally, there is fluid retention, because if the heart is not pumping the blood properly, the blood and other fluids will be accumulating into the different parts of the body, and eventually there will be edema in the different parts of the body. So as we earlier discussed, in the heart failure, the heart is unable to supply sufficient amount of the blood to the body. Now this may be because of two major reasons. Number one is the heart is not filling properly, or the heart is not ejecting the blood properly. So based on these two mechanisms, we call it or divide the heart failure into two major categories. Number one is the systolic heart failure, and second is the diastolic heart failure. Now, what happens into the systolic heart failure? The heart failed to contract effectively, or heart failed to contract properly. Now, if there is no proper systole, if there is no proper contraction of the heart will not be ejecting the blood in a sufficient amount and with a sufficient force. Now, if sufficient amount and sufficient force is not applied onto the blood will not be supplied to each and every part of the body. So reduced contractility and a reduced ejection fraction. Now what is ejection fraction? Now when a ventricle is filled with the blood, then the ventricles contract and the ventricles eject out that blood. Now in the normal situation, the amount of blood ejected by the ventricles is about more than 60%. Now roughly, if we say if 100 ml of the blood are filled into the ventricles, okay, more than 60 ml of the blood will be ejected from the ventricle on a single stroke. However, if the heart is not contracting properly with a proper force, so instead of more than 60 ml that has to be ejected from the heart, only 45 ml will be ejected from the ventricles, and the rest of the about 55% will be remaining into the ventricles. So the ventricles are not being contracting properly, or the heart is not contracting properly, and eventually the ejection fraction, the amount that has been supplied by the ventricle or moved from the ventricle is decreased. So we call it as the systolic heart failure. Now what happens during the diastolic heart failure? The heart fails to dilate properly. Now if the heart fails to dilate properly, the ventricles won't be filled properly. So as into the last slide, as we said, roughly there may be the ventricles may be filled with 100 ml of the blood. Now because of some abnormality, the ventricles are not dilating properly, and maybe 60 ml of the ventricles will be filled with the blood, or 60 or 50 ml of the blood will be filled with into the ventricles, and that blood will be removed out from the ventricle on a single contraction. However, ejection fraction may be normal even though stroke volume is significantly reduced. Now, maybe, as we said, normally the ejection fraction is more than 60%. Now, maybe ejection fraction in this situation of the heart is contracting properly, ejection fraction is 60%. But as in the last slide, if from 100 ml, if there is 60% ejection fraction, it will be about 60 ml. But if from a 50 ml, if ejection fraction is 60%, okay, the ejection fraction was same for 100 ml and for 50 ml. But of course, if the ejection fraction for 50 ml is 60%, the amount of the blood moved from the ventricle will be only 30 ml. So ejection fraction, contraction of the force of contraction will be same, but though because the ventricles have not been filled properly, only 50 ml of the blood was filled into the ventricles, so the 60% of that 50 ml will be only 30%, sorry, 30 ml. We call the heart failure as the congestive heart failure as well. Now why we call it as a congestive heart failure? Now as the heart fails, the blood flow out of the heart slows down, and blood returning to the heart through the veins backs up. Now heart is not pumping the blood forward, so the blood coming from the veins into the heart will be backing up, okay, because the heart is not pushing the blood. Now, if the heart is not pushing the blood forward, the blood will be backing up into the veins and eventually into the rest of the body. Now, this will result into the edema into the legs and the ankles. That is more prominent, but the edema and the swelling can also occur into the rest of the parts of the body. In certain situations, the blood will also be accumulating, or fluid will be also be accumulating into the lungs, and we call it as the pulmonary edema, and this will result into the shortness of breath. So next we have the underlying causes of heart failure. What are the factors which are causing the heart failure? The first of the underlying causes is the arteriosclerotic heart disease. So if there is more cholesterol into the body, that will be causing the stiffening of the blood vessels or the arteries, and in some such situations the cholesterol will be accumulating inside the arteries and narrowing down the space present inside the arteries for the flow of the blood. Now if the space has been narrowed down and the muscles have been stiffened, so the heart will not effectively push the blood through these narrowed down vessels or hardened vessels. Eventually, pressure onto the heart will be increased, workload onto the heart will be increased, and this will result into the congestive heart failure. Next is the myocardial infarction. Now, if there is any muscle damage inside the heart, okay, if there is any cardiac muscle damage inside the heart, the ventricles may not contract properly, the uh, atria may not contract properly, and if they are not contracting properly, the workload onto the heart will be increased. Okay, and that small damage to the muscles of the heart may increase into a larger damage into the muscles of the heart. And if the muscles of the heart not working properly, they are not contracting properly, eventually this will result into a heart failure. And by the time the problem will be increasing, as we discussed into the definition of heart failure, it is a progressive disorder. If it is not controlled effectively, it will be complicating by time. Next is the hypertensive heart disease. If the patient is suffering from hypertension, and if the blood pressure of the patient is not controlled in a proper manner, it will be putting continuous pressure onto the heart. The rate of contraction and the force of contraction will be continuously increased, putting pressure onto the heart. Okay, and the efficiency and working of the heart will be decreased. Next is the valvular heart disease. If the valves or the atria or the ventricles are not working properly, are not working effectively, they will be putting pressure onto the heart, and the heart will lead to the failure. Then we have the dilated cardiac myopathy. Now, if the pressure onto the heart due to certain reasons is increased onto the heart, okay, the muscles of the heart will dilate. Okay, the size of the heart will be increased. Why? To compensate the decrease into the blood pressure. Okay, to increase the supply of the blood to rest of the body. But this dilation and increase into the size of the heart, of course, will by the time will decrease the efficiency of the heart and the life of the heart, and it will go into the heart failure. Last factor over here, we have the congenital heart disease. There are certain problems into the heart that are present by the birth, and as the age of the person increases, these will be causing more complications. Now we will discuss that if there is a heart failure, how will be physiological response or compensatory physiological response if there is heart failure. So three things will happen if heart is not sufficiently supplying the blood to the different parts of the body. Firstly, there will be increase in sympathetic activity. Secondly, there will be activation of the renin-angiotensin-aldosterone system. And third, there will be increase into the myocardial hypertrophy. Now, if there is action onto the sympathetic activity, of course, this will be detected by the baroreceptors. Now, the baroreceptors are present at the aorta. Now, if the blood pressure is decreased into the body, the baroreceptors present at the aorta will detect that and cause the activation of the sympathetic nervous system. If the sympathetic nervous system activity is increased, as we have earlier discussed during the hypertension, it will increase the effect onto the beta receptors onto the heart, which will increase the rate of contraction of heart, and it will also increase the action on the receptors onto the blood vessels, the alpha 1 receptors, and cause the release of the endothelin, which will cause the vasoconstriction, and eventually the blood pressure into the body will rise up due to the contraction of the blood vessels. We have already discussed that the sympathetic nervous system will also be activating onto the renin and causing the sodium and water retention. The second response is the activation of the renin-angiotensin-aldosterone system. Now, if the blood supply is reduced to the kidney and there is less glomerular filtration, the renin will be released from the kidney. The renin will convert angiotensin 1 to angiotensin 2, and angiotensin 2 will act onto the blood vessels, receptors present onto the blood vessels, and it will cause the contraction of the blood vessels, and it will affect the heart and the vascular system, and eventually blood pressure will be increased. The angiotensin 2 will also be activating onto the aldosterone, which will result into the retention of sodium and water, and blood pressure will eventually rise. The third mechanism for compensating the decrease into the blood pressure due to the inability of the heart is the myocardial hypertrophy. The heart will increase in its size, and the chambers of the heart will become more dilate and will become more globular, and as a result of it, the heart will be contracting with a more force. There will be more stronger contraction to supply sufficient amount of the blood to different parts of the body. But this myocardial hypertrophy will be damaging the life of the heart. Though the heart will be supplying sufficient amount of the blood to the body, but there will be increased workload, and if there is increased workload on any part of the body or even any machinery, its efficiency will decrease by time. So these are the three main mechanisms for compensating if the heart is failing to supply sufficient amount of the blood to the body. Now, as earlier discussed, there will be different mechanisms into the body for the controlling of the blood pressure. Now, if because of those controlling mechanisms, the failure of the heart has been compensated because of the changes into the physiology of the body, if heart compensates for decrease into the supply of the blood, we will call it as the compensated heart failure. But even because of those controlling mechanisms, the changes into the sympathetic activity, the changes into the renin-angiotensin aldosterone system, the changes into the structural changes into the heart, if the decrease into the supply of the blood is not been achieved, we will call it as the decompensated heart failure, or we can call it as the acute heart failure. Now, as earlier discussed, the compensatory mechanisms which are going on to compensate for the decrease into the performance of the heart will result into the more decrease into the performance of the heart. As you see into the diagram, if you start from the left of the diagram, at stage 1, the cardiac output, the down arrow showing the decreased cardiac output because of the heart failure. And because of decreased cardiac output, to compensate that, there will be release of the norepinephrine by the sympathetic nervous system. There will be release of the angiotensin 2 by the renin-angiotensin aldosterone system. There will be release of endothelin as well, which will be causing the contraction of the blood vessels. Now, all these mechanisms will be causing the contraction of the blood vessels. Now, if the blood vessels have been more narrowed down to increase the blood pressure, the afterload, okay, the pressure after the heart, okay, the heart will be required to pump the blood to more narrowed down vessels. Now, if the heart is required to pump, a weakened heart is required to pump the blood to more narrowed down vessels, the ejection fraction will be decreased. Heart will be unable to pump more than 60% of the blood from the ventricles, and eventually the ejection fraction will decrease. Now again, if the ejection fraction is decreased, the cardiac performance will decrease, and to compensate that, more of the norepinephrine will be released, more angiotensin will be released, more endothelin will be released, and eventually again increasing the afterload. So if you see at the stage 2, more of the cardiac performance has been decreased, and if we move on, the performance of the heart decreases from day by day by day. Now, if we have a patient with a failed heart, so we'll be having two different goals. Firstly, to reduce the symptoms and slow progression during relatively stable periods, and manage acute episodes of decompensated heart failure. Okay, if the heart is going uh, in a normal manner, okay, with the treatment, carry on with it. And if at sometimes if the compensation paid by the body or compensation paid by the drugs is not sufficient, so we have to also manage those decompensated failures as well. So these include the different classes of the drugs that are used in the treatment of the heart failure. These include the angiotensin converting enzyme inhibitors, angiotensin receptor blockers, angiotensin antagonists, beta blockers, diuretics, direct vaso and venodilators, and inotropic agents. This table shows the list of the drugs from these different classes. These include the ACE inhibitors, which will cause the decrease into the blood pressure and decrease the load from the heart by inhibiting the angiotensin 2 and causing the relaxation of the blood vessels. These drugs include captopril, enalapril, lisinopril, lisinopril, quinapril, and ramipril. Next class is the ARBs, angiotensin receptor blockers. They will be blocking the receptor site of the angiotensin 2 and eventually causing the relaxation of the blood vessels and decreasing the workload from the heart. These include the candesartan, losartan, telmisartan, and valsartan. We can also administer aldosterone antagonists, that is the spironolactone or eplerenone, that are also involved into the remodeling of the heart. We have also already discussed the cardiac cardiomegaly, the increased size of the heart. So they will reshape the heart and also will be involved into the decreasing the volume of the blood by diuresis. Next are the beta blockers that will be decreasing the rate of the heart. And these include the bisoprolol, carvedilol, metoprolol, tartrate, metoprolol, succinate. Diuretics will be involved to decrease the volume of the blood and eventually the edema, the symptoms of edema will be relieved, the blood volume will be relieved and workload from the heart will also be relieved. In diuretics we have the bumetanide, that is loop diuretic, furosemide, that is also loop diuretic, torresemide, that is loop diuretic, and metolazone, that is a thiazide diuretic. We can also use the vaso and venodilators, which will dilate the blood vessels, uh, and it will decrease the afterload from the heart, and the heart will be able to pump the blood properly. And these include the hydralazine and isosorbide dinitrate. The last of the agent is digoxin, that is an inotropic agent. The digoxin causes the increase in the force of contraction of heart. It increases the inotropic effect, which is the increase into the force of contraction of heart. It will be affecting the sodium potassium ATPase and eventually causing the increase in flux of the calcium, which is involved into the myocardial contraction. More the amount of the calcium inside the cell, more will be the force of contraction and more will be the heart able to properly pump the blood. So all of the classes of the drugs defined earlier are very effective in the treatment of the hypertension, but there is a few of the advantages of some of the agents which are used in the treatment of the heart failure. First of the agent is the spironolactone. As we have already discussed, it prevents myocardial hypertrophy. The increased size of the heart, the remodeling of the heart will may result into the decreased functioning of the heart. So it will prevent the myocardial hypertrophy and brings the heart to its normal shape. Spironolactone has more disadvantages that it may cause the uh, aldosterone increase and gynecomastia may be present in the patient. So eplerenone is one of the more effective agent as compared to the spironolactone. Beta blockers also improve the systolic function and decrease remodeling, hypertrophy, and cell death. So they are also involved in the remodeling of the heart. Diuretics are also effective, as we have already discussed. They will reduce the symptoms of the volume overload. They will decrease the orthopnea. They will decrease the proximal noctural dyspnea, and the loop diuretics are more effective as compared to the other diuretics that are used in the treatment of the heart failure. The heart failure has been divided into three stages for the treatment purpose, and the order of therapy will also be based on these three stages of the heart failure. So, stage one is with high risk, but there are no symptoms into the patient, and this can be controlled with the patient education. At this stage, the disease can be prevented by patient education. If there is hypertension to the patient, it's one of the major underlying cause of the heart failure. So if we treat the hypertension, we will be uh, well enough to treat the heart failure as well. If there is diabetes, we have to treat that. If we have dyslipidemia, as we have discussed the arteriosclerotic disease, we can go for it. We have to treat these conditions with the ACE inhibitors or ARBs in some patients. So we will be uh, can treat the worsening of the heart failure. Now, if the patient has reached to the stage B, that is the structural heart disease, but no symptoms, there may be structural changes into the heart, but still the symptoms have not appeared onto the patient. So in these patients, we can go for the ACE inhibitors or ARBs in all patients, and maybe go for the beta blockers into the selected patients. But if the patient has reached to the stage C, that is structural heart disease, previous or current symptoms, okay, there may be some, now the symptoms will be present into the patient. So in such a condition, we can go for the ACE inhibitors, and we can go for the beta blockers in all patients. We can go for aldosterone antagonists. We can go for the fixed dose combinations of the hydroxyzine and isocyanide nitrates in selected patients. We have to go for the restricted dietary sodium. We can go for the diuretics and go for the digoxin as well. So finally, thank you very much for your time.